Dạ.
Question. Mike, huh? Oh, you just ask them what is the diagnosis for this patient.
Dạ, bây giờ cái câu hỏi của thầy là mọi người sẽ xem cái video và sau đó mọi người sẽ cho thầy biết chẩn đoán của bệnh nhân là gì. Mọi người xem video nhé, và mọi người hãy cho biết là chẩn đoán của bệnh nhân là gì.
So, what do you think? You want to ask them what they think?
Dạ, mọi người nghĩ, các anh chị nghĩ sao? Các anh chị nghĩ sao? Xin hợp tác.
Yeah. So this lady just presented with proximal weakness, was referred as myopathy, and she only has proximal weakness, CK normal, and the clue was the reflexes are reduced, and then when you after exercise, it comes back. And then from an electrophysiologist point of view, they will do a 20-second short exercise test and confirm the diagnosis. But if you don't suspect it, this can be easily labeled as a myopathy because the patient presents with proximal weakness only. And underlying diagnosis was she had Lambert-Eaton myasthenic syndrome due to a small cell carcinoma of the lung, which was only discovered after this. So after this, we went and did a CT thorax and found a small cell carcinoma of the lung. So important to diagnose it.
Dạ, các anh chị rõ chưa? Các anh chị như thầy có giải thích tới ta vì một cái yếu gót kim, thì sau đó khi mà thầy khám thì mọi người thấy lúc đầu thầy gõ phản xạ thì nó giảm, đúng không ạ? Rồi xong rồi khi mà thầy làm cái exercise ấy, thì thầy gõ lại cái phản xạ nó lại tăng. Nên là sau khi mà thực hiện cái exercise ấy, thì đây là một cái trường hợp tới và mình cứ nghĩ là bệnh cơ, nhưng mà khi mà chúng ta nghĩ tới chúng ta kiểm tra thì nó là hội chứng nhược cơ Lambert-Eaton.
So the Lambert-Eaton myasthenia doesn't look like myasthenia. They don't have the classic fatigue. They don't have the ptosis. Don't have ophthalmoplegia. They look like proximal. They look like a myopathy. So be careful.
Các anh chị nhớ là cái hội chứng nhược cơ Lambert-Eaton nó không có cái biểu hiện giống như là một cái hội chứng nhược cơ thông thường ha. Các cái triệu chứng của hội chứng nhược cơ thông thường thì nó sẽ không có điển hình trong Lambert-Eaton. Cho nên là cái hội chứng Lambert-Eaton đôi khi người ta tới với chúng ta lại nghĩ đó là một cái bệnh cơ với cái bệnh cạnh là yếu gót kim.
Okay, thank you very much.
Dạ, xong rồi ạ.
Yeah, so actually, if it looks proximal weakness, normal CK, yeah, so you have to be careful. Yeah, I would do a short exercise test. Is 20 seconds. So in our lab, the other clue is that the CMAP is always very low. The CMAPs will be low. So your technician should be trained that when the CMAP is low, unexplained, always do the exercise test. If it goes up by 50%, diagnosis.
Dạ, thầy có nói là trong cái trường hợp mà bệnh cảnh này á, thì cần huấn luyện cho các cái kỹ thuật viên phòng điện cơ á, nếu như mà cảm thấy một cái CMAP nó thấp mà không có giải thích được á, thì lúc đó phải thực hiện exercise test luôn. Và sau khi thực hiện exercise test á, thì đo lại cái CMAP đó, nếu nó tăng lật ngược trở lại thì lúc đó là chúng ta nghĩ tới cái là nhiệt tình. Thì cho nên là đây cũng là một cái thiết tự phải train các kỹ thuật viên. Dạ rồi, thì tới bây giờ thì chúng ta đã kết thúc cái 1,5 ngày cái workshop về bệnh cơ và sinh thiết cơ, thì em nghĩ rằng là có những cái bài giảng ví dụ như là cái phần trình bày ca, cái bài giảng gặp mặt của thầy Nishino là những cái bài giảng rất là đẳng cấp và rất là khó để có thể mời được hai thầy tới với đây với chúng ta và có những cái bài giảng đẳng cấp như vậy. Tất nhiên như em nói rồi, rất là khó để mà có thể là 1 ngày nữa chúng ta tiếp tục trình đó kiến thức. Tuy nhiên thì bọn em cũng đã dự phòng bằng cái cách thức là ghi hình lại tất cả những cái bài giảng từ hôm qua tới giờ và sẽ gửi lên cái QR code tài liệu này và các anh chị có thể download xuống được. Xin hỏi là tới bây giờ thì các anh chị còn câu hỏi nào để tới hai thầy hay không ạ? Dạ. Nếu các anh chị không còn câu hỏi nào tới hai thầy thì em xin phép thay mặt cho ban tổ chức rất là cảm ơn sự tham gia rất là nhiệt tình của các anh chị tới giờ phút này và hy vọng là có thể gặp lại các anh chị trong năm sau với một cái workshop khác, có thể là một cái workshop liên chuyên ngành khác, có thể là có thêm bên sinh học phân tử có thể tham gia cùng. Và trong 1 ngày nữa vừa qua nếu mà có cái vấn đề gì mà chưa được tốt thì rất là mong các anh chị thông cảm.
So you see, if you think about it, can you do this for me?
Làm như thầy.
Straighten. Then this way.
Rồi, làm như vậy.
No, this way.
Đây ngón út.
Okay, straighten this. So I'm wondering if it's a neurogenic process. So ulnar nerve comes this way, and then turns, serves the lumbricals, then comes to the last muscle here, right? So, but it looks like only this muscle is severely weak. The others are not so badly affected. So either it's a very distal neurogenic process or a very distal myopathic process. The most distal muscle is affected, you know, because in ulnar neuropathy, usually this will be weak. This will be weak. You know, this is lumbricals will be weak. And also this to some extent will be weak. Of course, this is the weakest because it's the most distal. But here, this one is really out of proportionally weak. This one all not too bad. So it's a very, very distal process. Right? Very distal process. So it can be a very distal motor neuronopathy, distal neuropathy, or a very distal myopathy. Very distal. Okay? Then this process is on push up from. It's strong. This muscle is also normal. Okay? Push down. Out. Out. This is very weak.
So isn't this split hand?
Split hand, right?
Right, split hand, right?
But it doesn't split hand. This is supposed to be weak also.
This is also weak.
This too. And this is bad.
I see.
A motor neuron, right? But in CMTX also they have that.
Yeah, this one is really.
This and this more than this. But here is this is also push up. Strong. But this is
Yeah, that's very weak.
Thì thầy có nói với cái kiểu này thì có thể là subdistal của cái neurogenic hoặc là distal của cái myopathy.
Okay, so let's look at his feet. Okay, can you hold on to the sides? Lift up this one.
Dạ, nhấc cái đùi lên này. Cái đùi.
Up.
Lên. Lên, hết sức giữ nha. Lên rồi giữ nha.
He's got some weakness.
Giữ.
Some proximal weakness also.
Yeah. Thầy thấy là có một
Push down.
yếu cả góc kia rồi đẩy xuống. Hết sức.
Can you hold the side?
Giữ.
Push down.
Đẩy xuống.
Okay, side open.
Rồi.
Okay, keep the legs up and then open like that. Keep the legs out and open.
Rồi, đẩy ra.
Like this.
Ok, làm như thầy ạ.
Up.
Lên.
Up.
Lên.
Push in.
Rồi, đẩy vào. Khép cái đùi.
Can you lift up his leg?
Đẩy cái
Difficult, huh?
cái ngón lên rồi xong khép vô.
Difficult. So he's weak here also. He's proximally weak here too. Push up for me.
Lên. Thầy check thì có cái yếu góc kia. Lên.
Okay. Quadriceps.
Dạ. Đá
Push up.
cái cẳng chân ra, hết sức.
Push up.
Hết sức.
Normal, right?
Dạ.
Push up.
Hết sức.
Push up.
Hết sức.
Okay, push it in.
Rồi, kép vào lại.
One more time.
Một lần nữa. Hết sức. Kép vô chặt.
Yes,
Kép
we
vô
go
chặt.
so. What about in?
Rồi, kéo vô. Kéo cái cẳng chân.
Weaker.
Dạ.
Weaker.
Yếu
Pull,
hơn.
pull.
Kéo vào.
Weaker and then push out.
Rồi đẩy ra lại nè, đẩy ra.
Strong. Push out.
Anh chị thấy
So
là
quadriceps is better than hamstrings.
cái cơ tứ đầu á thì nó tốt hơn, còn cơ chân
Okay,
lõng
push
nó
up
yếu
for me.
hơn. Ngóc cái bàn rồi.
Nothing moving. Okay, bring down.
Rồi đẩy xuống.
Very strong, huh? Okay. Toes up.
Ngón cái ngóc lên.
Okay, toes down.
Rồi gập ngón cái xuống.
Is weak.
Ngón cái gập có vẻ hơi yếu.
Okay. So normally for toes, what I do is put my fingers inside, ask them to curl in,
Cái thao tác khác.
and then I try to uncurl.
Cái ngón cái thì thầy cũng làm như vậy. Thầy
So
để cái
he has weakness
tay
of
xuống
toe,
đây.
toe flexion.
Sau đó là thầy gỡ cái khớp của các cái ngón ra.
Bring up.
Dạ. Ấp lên nè.
Down.
Rồi đập xuống.
Push down.
Rồi đẩy xuống. Đập cái bàn xuống.
Push out.
Ngóc lên.
Okay. Out.
Ra ngoài, vào trong. Đúng rồi.
In.
Rồi ra qua phía này.
In.
Rồi.
In. Okay. What about this one?
Anh thấy sao?
$100.
Đây là mà anh có thấy nó nhọn nhọn không? Thấy hả? Đây là 10 nha.
Here 100.
Bao nhiêu đây? Đây là 10, đây là mấy?
Ở trên em cảm nhận được 10 thì dưới nó tầm 8 9.
8, 9 hả?
Cái này
18,
này
18.
giống. Ngốt thì giống.
This one is 100.
Okay, this is 100. This is.
Cái này bao nhiêu?
Giống cho anh.
100.
Okay. So remember to allow the stick to move. You don't hold the stick because then you would be different strength, right? So you allow the stick to move. So this is 100. This is
Bao nhiêu?
Cái này chỉ 7 8.
70, 80.
this one.
Cái đó bao nhiêu?
Cái này nhiều hơn chút.
Bao nhiêu?
Ở 8
80. Bao nhiêu?
giống.
100. 100.
100. Okay, here.
Ở đó nhiêu?
Để tại
Bao nhiêu? Cứ nói đi anh.
nó chừng 5 6 gì.
6 hả? 60. Bao nhiêu? Tốt hơn chưa?
Đâu không?
Bao nhiêu? Ở chỗ nào tốt hơn? Ở đó là bao nhiêu?
Ở vùng ngay ngay trên đây.
Là 100. 100.
100.
Yes.
Here not 100.
Yes.
Here.
Đó thì sao?
Giống gì?
Bao nhiêu?
Ở
Ở dưới đó là bao nhiêu?
ở 90.
90.
90.
Yes.
Okay, let's concentrate again and try. Yeah?
Giờ tập
So this
trung
is
nha.
100.
Đây là 100 nè. Được chưa?
Okay, and how much is
Đây
this?
là bao nhiêu? Đây là 10, đây là bao nhiêu?
Cỡ 80.
80.
80. So when does it become 100?
Khi nào thì lên tới 100 anh nói nè. À lên tới 10. Chỗ nào? Đó hả? Là lên tới 10. Ok. Chỗ nào?
Okay, let's try again.
Rồi, bắt đầu nha. Khi nào lên tới 10 nói em.
No, it's over here. So not much change, but there is some subtle. Okay, let's try this one. Okay,
Thấy rung không?
okay.
Thấy rung không? Khi nào hết anh nói nha. Stop.
Normal, huh?
Thấy rung không? Khi nào hết anh nói nha.
Okay, cold,
Có lạnh không? Có thấy lạnh không? Dạ, lạnh.
same,
Giống nhau không?
Cái này lắm rồi.
More lạnh.
colder
More
there.
cold, yeah.
Here,
Bên kia thì sao?
Ở trên này.
Yes.
there is, okay, last one, then we are done. Oh, I ran out of tissue. Do you have tissue? Any
Dạ,
tissue?
mọi người có cái khăn tissue không? Khăn giấy mềm. Dạ, em trang. Ở đây.
This is fine, yeah. Okay, so can you close his eyes and you know that?
Nhắm mắt nha. Bây giờ thầy chạm vô chỗ nào biết anh chỉ tay vào đó cho em nha. Rồi, bắt đầu.
Normal, huh? Okay, the last thing I do is for thickened nerves, huh? So must check for thickened nerves.
Cuối cùng là thầy xem có cái dấu hiệu dày các cái dây thần kinh hay không.
So thickened nerves, look here,
Vị trí đó là vị trí thầy hay kiểm tra.
here, here. So far nothing. And then in the hand, the dorsal ulna is here, dorsal ulna, and radial. It looks normal to me, not thickened. And then finally, draw a line between this and your trapezius, this line. If there is a thickened greater auricular nerve, you can be able to see it. So you draw a line like this, okay? Turn this way, sir. Usually I use the torch also.
Thầy có chỉ chúng ta ở các cái vị trí mà mình khám để mình phát hiện cái dấu hiệu dày các cái dây thần kinh, các dây thần kinh dày.
So you will see a line here, that will be the greater auricular nerve. So no, he's not thickened. Okay, and then finally, open your mouth. No fasciculations,
Không có fasciculation,
no wasting,
không teo.
pupillary response,
Rồi bây giờ thầy khám cái phản xạ đồng tử
normal.
bình thường.
Okay. So my guess is that it's either a distal myopathy, anterior compartment involving more than posterior compartment, or a very distal motor neuropathy, right? But I will favor distal myopathy. No, not really. Cannot say between the two. Both possible. Okay, so EMG, CK,
EMG is
myopathic, huh?
sensory nerve stimulation is
Normal. Huh?
How about EDB? EDB is
EDP is normal though.
normal, really.
Sorry, it is wasted.
Wasted.
So that's why I
I think
was
it's more like neuropathy.
Neuropathic. That's why I say
Because
cannot differentiate.
I don't know any muscle in distal myopathy that affects EDB actually from
Exactly.
others, right?
So that's why I say cannot differentiate between the two. But can I just ask about the GNE myopathy, the quadriceps sparing, right?
Yeah, right.
So that is relative to strength in proximal muscle? Meaning, when you say quadriceps sparing
I think
means
it's where at certain moment it's really full, 5, not relative, it's 5.
5,
full,
right? Yeah, so his is 5, but his
Yes.
flexion, hamstring is weaker, and his hip flexion is weaker. So is this considered quadriceps sparing?
No, so
You see, I'll show you. Huh?
Chỗ này thực ra là thầy có nói là thầy Ichizo có nói là bởi vì cái EDB
Okay,
là
you watch,
bị
huh?
teo.
Okay, lift up from.
Nếu mà EDB bị teo
So that's
thì
weak.
nó có vẻ
Right.
Push against me.
bệnh cơ lắm.
It's very strong. Pull. This is weaker.
how about the
It's also weak. This, squeeze in.
yeah, adductor magnus and how about the
Abductor also.
It's weak.
Weak also.
I see.
All of them are weak, but his quadriceps relatively spared.
I see.
So I personally think that it can be a neurogenic process also, because a very distal neurogenic process. So, or a distal myopathy. So, EMG is tricky, you know, because if you do these muscles, they can look very myopathic when it's actually neurogenic.
we do in the
Or proximal, yeah, good.
we do it twice.
Actually, in GNE myopathy, subscapularis muscle is affected.
Subscapularis.
Yes,
Oh,
so
is it?
you- maybe you
shall we
can
test?
try
Come,
that one.
stand up. Let's learn this
Yes.
new technique. Yeah, turn around, sir. The subscapularis.
Yeah, lift off
Ah,
sign.
okay,
yes.
so you put your hand like
Yeah,
this.
you put, yes. Okay, so push my hand back. Tell him to push my back.
Push.
Đẩy cái ba tay của thầy
Yes.
anh, đẩy cái tay của thầy.
No, not
Okay,
like
let's try whether you can do
Yes,
it passively
yes.
without your hand.
Okay, push
Press,
back, push back.
like this.
No, not like that. Like this.
Yeah, like this. You see what I'm doing?
Yes. He can do it. Okay, push,
Oh,
push,
no.
push.
Okay,
Yes.
push.
Yes, push. Yeah, no
Can,
problem
huh?
at all.
Okay. Now, just one more time. Because I wonder whether he was extending. Push out.
No, he uses this
Yeah,
one. Yeah,
that's right.
why.
So it could be,
No, actually, no.
You see, this is my normal, right?
Yes.
Look at me, and this guy, push out, like this.
So
He's very stiff there.
do this.
Làm như thầy vậy.
Okay, just
Yeah.
extending.
Yeah, I think this is fine.
This is fine, is it?
Yes. Yeah. And okay, do this. Sorry. Do this. Yeah, I think this.
It's fine, huh?
Yeah, fine.
Okay, this one,
Yes.
push out. Can you ask him?
Actually, I think this is very tricky examination.
Because
but I
it-
think,
yeah,
you
you can cheat.
Exactly. But I think it's very difficult. Not
So
to use.
if you look at this, push out.
Đấy.
So I see for me now,
Yeah.
I can do this.
Right.
But then it's also dependent on how stiff you are.
Right.
A lot of people can't put their hands behind. Right? Can you do that?
Can you do this?
You can, huh? Maybe we should ask them to hold their hands. Huh?
Yeah.
Okay, push like that. Push out.
Đấy. Để sau.
Maybe difficult. Yeah. Maybe.
So you see, with me, I can do this.
Right.
Yes. Mọi người nhìn ha.
He has difficulty. So,
Thì là không làm được.
but then the EDB is very wasted, right? What do you think? Come sit down. You have a look.
Ngồi xuống.
Show him the thing. Bring it up.
Gấp.
This one.
Gấp cái bàn chân lên. Cái bàn chân đó, cái bàn chân.
Is it up? Is it up?
Lên.
No EDB, right?
Right.
Lên.
Can I see him walking?
Yes.
Walk, sir.
Rồi, anh đi tới cái mục kia giúp em ha. Rồi đi lại ha. Đi tới đi lui đó.
So in GNE myopathy, often the toes go up because
toe what? Sorry?
the toes
Go up.
Go up because to somehow try to compensate, the weakness of the tibialis anterior. But I think his toes are like this,
Exactly.
almost like this.
So actually, I agree with him. So I noticed, remember I've told you before, if when you bring your foot up, usually the big toe is the weakest if it's a neurogenic process, all neurogenic process. But in myopathic process and central nervous system, you notice that the big toe will come up first because the big toe in the brain has got bigger representation. So cortical wrist foot drop as well as myopathic foot drop, the big toe is often not so bad. In neurogenic process, the big toe is the worst. I find. So I think this again that you lie down, sir. See,
and he
you
walks
see,
like
he
this.
doesn't. You see, like patients with neuropathic process, the big toe will come up first, and then you'll come up. Myopathic process, big toe.
Nhìn cái myopathic
But for him,
process
the big toe is the weakest. Bring up.
Dạ lên.
Okay, this one.
Rồi cái chân bên này.
Bring up. Big toe is the weakest.
Nghĩa là trong cái hình thái này thì
So not sure.
cái ngón cái nó có vẻ
Right.
không phù hợp.
I've
Yeah, of
Fine.
course, eventually it also
Sure.
affected, but I think at this stage, I think they usually, toes go up. Yes.
But I find EMG difficult in these such cases.
I see.
Honestly, I'm very scared about such EMGs because can look very similar because sometimes these muscles are very normal, so very difficult. You choose the abnormal muscle, it's too abnormal. So I find it very difficult.
Tôi nghĩ là cái điện cơ nó sẽ rất là tricky trong cái trường hợp này.
I want to see muscle CT or
Yeah,
MRI,
muscle CT will
actually.
be good.
That will be very
Okay.
helpful.
Okay, you wait for a while. Sir.
CK 700. Okay.
700.
Can be either neurogenic or
Yes,
myopathic.
700 is just the right number
Yeah.
for both.
And EMG we check both
Spontaneous activity?
like if
Okay. Yeah. Right. Okay. Yes. Thank you. That will be. Okay. Good morning. So I will talk about muscular dystrophy. This is my disclosure. Okay. I know this. Oh, sorry. I know this sign. I know you know this sign, right? This is Gower's sign. But my question is, in this kid, in this boy, which muscle is most affected when he shows this sign? This is my question, okay? So when he stands up from this, squatting position, you have to extend 3 joints, right? Ankle joint, pointer, here. Ankle joint, knee joint, and hip joint. So let's look, let's focus on 2 big joints, knee joints and hip joints, okay? So I actually analyzed his video maneuver frame by frame. So he took actually 2.7 or 2.8 seconds from this position to completely standing up, okay? Very interestingly, only after 0.1 second, he already extended his knee joint, right? Right? But for the so this is knee extension. For the remaining time, all of the remaining time, what he was doing is he was extending his hip joints, right? Like this. So it means that he took a long time to extend his hip joints. So this means that his maneuver, this sign shows he has difficulty extending his hip joints. Okay, I will show you the same video again. It will look different. Okay. He already extended his knees, but he took a long time to extend hip joints. So it looked different, right? Once you understand, it will look different. So you shouldn't just say, oh, Gawa is positive. This is not enough. You should more carefully examine patients, okay? And by the way, for knee extension, you use quadriceps, right? And for your hip extension, you use gluteus maximus muscle. So let's look at the MRI. So this is a different patient. Unfortunately, I didn't have MRI at that moment. Look at his hip muscle, gluteus muscle. Really white. It means that this at T1, the white color, white signal means, high signal means fat, right? So the fat is really infiltrated in gluteus maximus muscle. While look at quadriceps, of course you see a little bit of fat, but much better preserved, right? So this is very much compatible with his maneuver, right? Because he has difficulty extending his hip joints, but quadriceps, knee extension is okay, right? Right. And quadriceps is well preserved. So this is often the case, at least in the early stage, the Duchenne muscular dystrophy patients in the early stages. This is exactly the same patient after 5 years. Now he has difficulty extending his knee joints. That's why he has to extend knee like this. Then he has more difficulty. He takes even longer time to extend his hip joints. Now you can tell his knee joints, the knee joint extension is also affected. So this is his CT. Clearly, in CT, dark color means fat, right? So clearly his quadriceps muscle is infiltrated by fat. So actually, see, comparison between imaging data and motor function or action, patient's action, is very important, and this helps you to understand the patients better. Okay, I will go through DMD first. So this is the Duchenne muscular dystrophy patient. As you know, Duchenne muscular dystrophy patients usually they typically show high CK around 1 year, and they started having muscle weakness like maybe 2-3 years. And typically they lose ambulation around age 10, and they develop a respiratory failure and eventually cardiac failure. And as you know, milder form is Becker muscular dystrophy. And if you do immunohistochemistry, typically, dystrophin is completely absent, while in Becker muscular dystrophy, you can see faintly it is expressed. Okay, DMD gene has 79 exons from 1 to exon 79, and where it encodes a big protein. And as you know, around 70% of patients are caused by exonic deletions or duplications. And if this is out of frame, then it will be Duchenne muscular dystrophy, but it is in frame, then it's going to be Becker muscular dystrophy. And about the remaining patients, like 30% patients, usually have nonsense mutations in Duchenne muscular dystrophy, while missense mutation in Becker muscular dystrophy. So this is our cohort. So as I mentioned, like 56% of patients have exonic deletion and 14 have exonic duplications, altogether 70%. So this exonic deletion and duplication can be diagnosed by MLPA, which is a very easy method. And for the remaining patients, you need sequencing of the exonic region. MLPA, multiplex ligation probe amplification, is a very easy test. If you have exon, then you have peak like this, right? And which exon is present, you can tell. And if you don't have certain exons, particular peaks are lost. So that's, then that's how you can tell which exons are deleted or not. This is very easy test. But the tricky one is this one. So as I mentioned, typically Duchenne muscular dystrophy have nonsense mutations, okay, 4-point mutations. But this is a little bit tricky. We actually recently did some study. So those cases had nonsense mutation. All of them had nonsense mutation. And also they received muscle biopsy. Interestingly, marked by red color indicates positive dystrophy. It means that they don't have Duchenne muscular dystrophy. The phenotype is Becker muscular dystrophy. And many of red colors are interestingly located in the in-frame exon. And we found that by this point mutation, luckily, so you expect that the translation stopped there. But actually, by this nonsense mutation, actually this exon is skipped out. So that's why it becomes Becker muscular dystrophy phenotype. This was what we found. And another one, the last 1% is still undiagnosed. We actually had discussion with one DMD case yesterday, right? Undiagnosed case. For this, you need muscle biopsy, and you really need, deep sequencing. So we actually did targeted long read sequencing and also RNA-seq analysis. So you really need, deep analysis. And of course, it's very complicated. So we did this this is called sashimi plot. You know sashimi? You know sashimi, yes. So this is called sashimi plot. So normally, for example, this one is, the blue one is control. So this certain particular exon and exon. So this exon and this exon is spliced, right, connected. But in this particular patient, they have mutation in deep intron, and this part of the intron is recognized as exon. And that's why this is connected, and this causes stop codon. This produces stop codon. This is why they show Duchenne muscular dystrophy phenotype. But, for example, this one, yes, this causes, this is called pseudoexon, and the pseudoexon induces a stop codon. But not everything is connected like this. Some of them are, only some of them are normally spliced. So that's why in some cases it will become Duchenne muscular dystrophy, but in some cases you still see some dystrophin positive fibers, just like yesterday. I forgot which case, but yesterday's case is one of these. Yes, so had really complicated mutation in deep intron. So 1% of undiagnosed cases in our series, at least, they have deep intronic mutation. For this, you really need, the usual sequencing analysis will not give you the diagnosis for this one. Okay, now the therapy for Duchenne muscular dystrophy has been developed, but first of all, their lifespan is really prolonged. This is not because of the treatment. Actually, respiratory care, cardiac care, and management has been greatly improved. This is why their lifespan has been really improved. And rehabilitation, physiotherapy is also very important. This helps preventing the joint contracture. And steroid therapy, the efficacy of steroid has been shown by a large clinical trial, and the period of the duration of ambulation has been really improved. Then root therapy. Okay, so as I mentioned, the survival is prolonged. They are the cases born before 1970. So the average lifespan was like 18 years. But those who were born after 1990, now the average lifespan is 18 years. So 10 years prolonged, right? And the efficacy of steroid therapy has been proved by several trials. Sorry, it should be lower limb, and this is upper limb. I was switched. But anyway, so as compared, this is the control, which basically without steroid, and the red one is with steroid. So see, it's all prolonged. So let's say, for example, loss of ambulation was around age 10 without steroid. But now with steroid, 13 years, so 3 years prolonged, right? So it's clearly efficacious. So then root therapy. So there are several clinical trials for Duchenne muscular dystrophy, and of course exon skipping therapy is already available for certain mutations. But the most important, probably the biggest recent news is gene therapy. So gene therapy was, first gene therapy for Duchenne muscular dystrophy was just approved by FDA, but it costs $3.2 million. Maybe cheap for you, but very expensive for me. Yeah, but theoretically you need just one shot in all of your life, right? But of course you never know. In the maybe 30, 40 years, you never know. And also this is not the complete, curative therapy, because the capacity of the vector they use is not very big, while dystrophin gene is very, very big. So they have to cut down the gene size. So actually what you can express is not full dystrophin, but mini dystrophin. So theoretically, if this is even if this is perfectly efficacious, what you get is Becker phenotype, milder Becker phenotype, not really the normal phenotype. But still, this is very good news for patients. Okay, now I'd like to talk about limb-girdle muscular dystrophy. So limb-girdle muscular dystrophy the term was first used by Walton and Natras already 70 years ago. And this was originally described as a muscular dystrophy but different from Duchenne or Becker. Okay, so because the definition is well, basically the exclusion of other well-established muscular dystrophy like Duchenne-Becker or facial scapular muscular dystrophy. So this is, in a sense, like wastebasket of the, the classification. So that's why, a lot of, different heterogeneous group of disorders are included. So I skipped this slide yesterday, so I will talk about it a little bit. So until recently, dominant form was classified as LGMD1, and recessive form was classified as LGMD2. And by the, if you identify new causative gene or locus, then they put A, B, C, D in the order. So the first dominant limb-girdle muscular dystrophy identified was named LGMD1A, and the second one 1B, like this. And for the recessive form, the first one identified was LGMD2A and 2B, blah, blah, blah. This was okay, but they had a big problem because LGMD2 already reached Z, the last letter. So then, clearly, you need a new system, right? And there was a discussion. Then they decided to change LGMD1 to LGMD-D for dominant, and LGMD2 to LGMD-R, R for recessive. This is a good idea. Then they put number instead of ABC. So LGMD-D1 or LGMD-R1, R2, R3. Then you can continue forever, right? But yeah, I will magnify this part. But not everybody is so happy about this one, because look at this one. LGMD1A, 1B, 1C were excluded. They said that they are non-limb-girdle muscular dystrophy, right? But how can you say that? Because many people believe that they are limb-girdle muscular dystrophy. And another point is this one. They were newly added. They are called 6A1, A2, A3. They are actually Bethlehem myopathy. So people call it myopathy, but they include it to muscular dystrophy. And another important point is there was a rule, like one gene, one name. But then all of a sudden they said 3 genes, 1 name. So it's a little bit really confusing. And another one, this one, LGMD2C, 2D, 2E, 2F. They are all sarcoglycanopathies, sarcoglycan deficiency. There are 4 subunits, sarcoglycan, there are 4 sarcoglycan subunits, alpha, beta, gamma, delta, okay? But the first sarcoglycanopathy identified was gamma sarcoglycan deficiency. This is why LGMD2C is SGCG, G for gamma, right? This is historical reason, right? Then ABD, this order. But they changed the order. So A, alpha 3, and B, beta 4, then gamma 5, and delta 6. Because they said that for people outside the field, this is confusing. Gamma, alpha, beta, delta order is confusing. But this is because of historical reason, because the order of identification was different, right? But they changed it. So actually there are really irregularities, yeah, right? So actually not everybody is happy about the new nomenclature. So there was actually a meeting to further discuss new nomenclature for limb-girdle muscular dystrophy, okay? And I was involved I was part of the steering committee, but I couldn't attend it, because I had to attend other meeting. And the conclusion from this meeting was no conclusion, because everybody has different opinion. But now many people somehow agree we have to use gene-oriented name, right? So for example, dystrophin deficiency. Maybe one idea is DYSF dystrophy, DYSF MD recessive limb girdle, something like this. So MD means you may think this may be muscular dystrophy. No, muscle disease. Because the distinction between muscular dystrophy and myopathy may not be so clear for sometimes. So they just say muscular dystrophy. Or maybe dysferlin, DYSF, limb girdle muscular dystrophy. Or limb girdle muscular dystrophy, DYSF, something like that. But we couldn't reach the conclusion. In our field, we often use the term dysphrenopathy, sarcoglycanopathy, calpainopathy. Maybe this is useful, but this was not accepted by people from OMIM. They said that, well, calpainopathy, dysphrenopathy, okay, you guys understand this is muscle disease, but for people outside the field, you don't know what kind of disease it is, right? If you just say dysphrenopathy, this may be kidney disease or brain disease or something else, right? You never know. So you have to have something which indicates muscle disease in the name. So this will not be accepted. So anyway, we don't reach the conclusion, but still, most likely we will have gene-oriented name in the near future. Okay, so depending on which nomenclature you use, of course, the percentage of the muscular dystrophy will be included, will be different. With traditional nomenclature, well, LGMD2B is the most frequent, and the second most common is 2A. With new nomenclature, LGMD R2 and R1 are the most frequent, but anyway, the same, dystrophin deficiency and calpain-3 mutation. So calpainopathy was originally identified, the first identified recessive limb girdle muscular dystrophy, and there are more than 600 different causative mutations identified. But more recently, there was a dominant form of calpainopathy. This is now called D4. They have milder phenotype, yes. And this is the dominant form. I don't go into the detail, but I didn't clearly show that the amount of calpain-3 is decreased with this dominant mutation. But they have milder phenotype than typical recessive form, as this one. The original one, R1 or 2A, was originally identified in the island, Reunion Island, off the coast of Madagascar. This was a French colony, and you may think that these patients are actually the original, people here, but actually not. They are French descendants. So the patients are French people. Okay, so let's check the video again. So which muscle is more affected, hip or knee? This is a little bit tricky. He took some time to extend his knee, but I think he used his hands to push up his hip joints. So probably his hip joints, gluteus maximus muscle is more affected. So in fact, you see, his gluteus maximus muscles are infiltrated by fat, but quadriceps muscles are relatively well preserved, right? So I think that the pattern is somehow similar, in a sense similar to Duchenne muscular dystrophy.
Is that why his ankle was big? What about ankle?
Sorry?
His ankle.
Ankle? Yeah. Well, actually, with ankle, I think it doesn't probably affect, standing up. Yeah, I think. Yeah.
Because he was.
Yes, it is affected. Yes, you are right. Yes. Probably you don't need this power that much to stand it. Right. Oh, you want to show it? Right.
He's not really. His ankle is that he's already got a contracture there.
Right, I see. Okay, maybe you are right. Okay. Yeah, so hip muscles are affected while quadriceps are well preserved. And sometimes we see scapular winging like this, right? So when you see scapular winging, many neurologists almost immediately think about FSHD, and sometimes confusing actually. Scapular winging in FSHD, of course in FSHD you see asymmetric muscle involvement like this. But even for this, actually muscle imaging is very powerful. There are 4 rotator cuff muscles: supraspinatus muscle, subscapularis, teres minor, and infraspinatus. Teres minor is really little one, but for muscle imaging, you can observe supraspinatus, infraspinatus, and subscapularis. Subscapularis is at all those muscles attached to the scapula. But subscapularis is present the frontal side of the scapula, and supraspinatus is present. Supraspinatus and infraspinatus are present on the back side. Okay? All right. So very interestingly, in LGMD-R1 or calpainopathy, subscapularis is very severely affected. Maybe all others also affected, but the most important one is subscapularis is the most severely affected. But also other rotator cuffs are affected according to this study. In contrast, in FSHD, look at this. All those rotator cuff muscles are least affected, especially subscapularis. Really, this is the least affected muscle, right? Basically, those rotator cuff muscles are not affected, but especially subscapularis. In contrast, trapezius muscles are really frequently affected. So this is the feature of FSHD. And look at this one. This is CT and a little bit difficult, but this subscapularis muscle is a little bit dark in color, right? So you can tell this is affected, while other muscles are still preserved. In contrast, in FSHD, subscapularis muscle is well preserved, not affected at all. And this is also the case actually in other rotator cuff muscle, infraspinatus as well. But in contrast, if you look at trapezius muscle, actually this trapezius muscle is gone. So how can you evaluate subscapularis muscle? This is a little bit tricky. This is called lift-off test. So the function of subscapularis is internal rotation of your arm, this movement. So the maximum movement is this one, right? So you ask the patients to keep this position, and you place your hand and ask the patient to push your hand, okay? And you immediately remove your hand, and if it is normal, of course the patient's hand will be moved like this. But if your patient has weakness, this doesn't go like this. But yeah, this is theoretically like this, but it's a bit tricky. It doesn't work very well. I tried many times, but this is the test when the patient has subscapularis weakness. And actually, for example, even in the late onset Pompe disease patient have this type of scapular winging. Keep trying to connect to a white fiber. But anyway, so this, yeah, right? So also in late onset Pompe disease, supraspinatus, infraspinatus, subscapularis, they are all affected, right? That's why actually, if you look at this, these muscles are very thin, right? Because you can tell that even infraspinatus is atrophic. And also, of course, paraspinals are also atrophic. So, yeah, of course, you can make a diagnosis, but there is difference. Okay, so now I'd like to discuss the muscle pathology. In LGMD1, of course, you see necrotic fibers. You see this is a cluster of necrotic fibers, just as Duchenne muscular dystrophy. But calpainopathy is not due to membrane fragility. So nobody knows why. Yes, but this must be associated with mechanical stress because all fibers in this region were apparently necrotized at the same time. But this is not because of membrane fragility. We still don't know the reason. And also another point is you see a lot of eosinophils. Actually, calpainopathy used to be reported as eosinophilic myositis. Of course, this is not myositis. I don't want to accept that type of concept, but it was reported as eosinophilic myositis. And another thing is this one. This is called opaque fiber. Opaque fiber is actually hypercontracted fibers. So when I talk about the mechanism of necrosis, when you have a hole, small hole in the muscle fiber membrane, and calcium will come in, right, focally, then hypercontraction occurs. This is the hypercontraction. So if you have membrane fragility like Duchenne muscular dystrophy, even if you do muscle biopsy, very gently, you pull a little bit, right? By pulling the muscle during muscle biopsy, you get opaque fiber like this. But in LGMD-R1, you usually don't see opaque fiber. So it means that this is not due to membrane fragility, right? This is also the difference. This is the one I mentioned. I really don't like this paper, but they say that, yes, calpain-3 mutations with eosinophilic myositis. Of course, this is totally unacceptable. So we don't know why, but for some reason, eosinophils are often come to the necrotic fibers. Of course, this is not myositis at all. Yeah, this is also the case, reported from American guy as well. Okay, on muscle pathology, actually I showed the same picture yesterday. We often see lobulated fibers, yes, like this. And, well, I'll skip this one. And interestingly, in calpainopathy, in the early stage, we see a lot of necrotic fibers. But necrotic fibers will disappear, and in later stages, we see a lot of lobulated fibers. Yeah, okay, so this is the summary. So anyway, this is adult onset limb-girdle muscular dystrophy, and scapular winging is sometimes seen, but subscapularis involvement is the important, the key feature to differentiate from facial scapulohumeral muscular dystrophy. And dystrophinopathy, although OMIM don't want to use the term dystrophinopathy, but dystrophin deficiency. And this is actually the most common limb-girdle muscular dystrophy, probably in various areas. And there have been more than 600 pathogenic mutations identified. And there were two major phenotypes. One is Miyoshi myopathy. Miyoshi myopathy is a distal myopathy, one of distal myopathy. The other one is limb-girdle phenotype. The question was, are they truly different or not? Yes, Miyoshi myopathy was originally reported by Professor Miyoshi, yes, and he pointed out that calf muscle is severely affected. And if you look at muscle CT, the whole calf, gastrocnemius, and also soleus muscle are all gone. And from outside, of course, the calf muscles look thin. That's why they call it distal myopathy. And this was reported already 13 years ago. This paper from Spanish group mentioned that by imaging analysis, limb-girdle muscular dystrophy 2B, now R2, and Miyoshi myopathy, they show exactly the same pattern of muscle involvement on muscle imaging. No matter some people, if you call it limb-girdle or Miyoshi myopathy, they actually show exactly the same pattern of involvement. This is the thigh muscle, this is the gastrocnemius, so this is the lower legs. So even in the limb-girdle muscular dystrophy cases, in the early stage, already gastrocnemius is affected, just like Miyoshi myopathy. Right? So it really depends on which muscle you focus on. And this is more recent paper. So they actually analyze all the muscles. So they found that, so this is Miyoshi myopathy, and this is limb-girdle muscular dystrophy patients. So in both conditions, less affected muscles are less affected. The highly severely affected muscles are highly affected, severely affected in both conditions. And the pattern is exactly the same. So now they think that they are the same disease. And actually, one of the students of the Professor Miyoshi often said that, okay, when he traveled to the US or Europe to attend the meeting, he said that all the limb-girdle muscular dystrophy patients reported by European or American group have Miyoshi myopathy in his eyes. So he was correct, yes. So now we think that Miyoshi and limb-girdle muscular dystrophy are the same disease. Okay, now let's see how she stands up. See, this one doesn't have much problem, right? This one is more striking. See? Of course, this maneuver is not purely by gluteus maximus. She uses back muscles as well. This guy, he lost ambulation already. He can't walk. But he can do this, right? So clearly, in this disease, the quadriceps muscle should be more affected than gluteus maximus muscle, right? So this is his MRI. Look at this one. So there is almost no quadriceps muscle, right? But the gluteus maximus muscles are well preserved. So again, the maneuver, the action is very different, right? You can somehow tell. And of course, gastrocnemius muscle is also involved. Yeah. So this is the paper. They actually extensively analyze which muscle is affected by imaging data. And clearly, all those quadriceps muscles are really markedly affected, while gluteus maximus muscle is relatively well preserved. So this was discussed yesterday by Dr. Umapathi. So this is called bulled biceps. And actually, by Dr. El Sharif from Egypt, she actually did imaging study. And she found that this phenomenon is because of the lower part of biceps brachii are affected earlier than upper part. So only the upper part remained in some period of time. Yes, that's why you see the ball here like this. But of course, in the advanced stage, this ball will also be all gone. Yes. So only in certain stage you will see this type of phenomenon. Okay, so on muscle pathology, of course, you see this type of necrotic and regenerating fibers. But sometimes, in the previous time, some papers described lymphocyte infiltration, marked lymphocyte infiltration. Yeah, we sometimes see it, but they always present only in perimysium. So as I discussed yesterday, lymphocyte infiltration in perimysium are non-specific. We never make a diagnosis of myositis. But some people, a long time ago, like 20 years ago, some people say that, oh, dystrophinopathy may be myositis, but it's not, because lymphocytes are all present, always present in perimysium only. And if you do muscle biopsy, the diagnosis is relatively easy, because dysferlin is normally present in the muscle fiber membrane, but it's gone. But of course, you can do. You can also demonstrate the loss of dysferlin by Western blotting like this. So dysferlinopathy is the most common subtype in Japan at least. And yeah, okay. And now we know that limb-girdle and Miyoshi myopathy are the same disorders. Yes.
So I don't understand when you say it's the same disease, but clearly some patients are weaker here than. So you're just saying that the stage of disease is different in different patients, but the same.
I think always there are variations, yeah, right. But on average, I don't think there is any difference. So even in what they call Miyoshi myopathy, actually quadriceps muscle are relatively, severely affected. So I think there are some variations, but overall they are the same disease. So there is a called anoctaminopathy. Maybe the OMIM people don't like this term, but which is caused by muscular dystrophy caused by ANO5 mutation or anoctamin 5 gene mutations. In this disease, actually, the calf muscles are markedly, preferentially affected. This is why they call non-dysferlin Miyoshi myopathy, right? But at the same time, limb-girdle muscular dystrophy as well. So it's very similar to dysferlin. Yes, and actually the clinical phenotype is very similar to dysferlinopathy. But maybe the only difference is more asymmetric like this as compared with dysferlinopathy. And they often complain myalgia as compared with dysferlinopathy. And myalgia is rare in dysferlinopathy, but it's frequent in anoctaminopathy. But otherwise, it looks very similar to dysferlinopathy. Okay, then yeah, this one is included. And this is, is collagen 6 related myopathy or muscular dystrophy. The most severe one is called Ullrich congenital muscular dystrophy, while Bethlehem myopathy is the milder form. And this is now included, according to them, to limb-girdle muscular dystrophy, but not everybody follow their idea. This is the Bethlehem myopathy patients. Again, I will ask you which muscle is most affected. So clear, right? So quadriceps muscle should be affected, more affected than gluteus maximus muscle. So this is his muscle. See? Of course, you see a little bit of fat infiltration, but gluteus maximus muscles are relatively preserved. But his quadriceps muscles are really affected. But the pattern is very interesting. Not everything is gone. You still have some muscle left, right? This looks like fat comes from outside, and only the inside, the muscle is still left, still there. This is like a from outside to inside pattern. This pattern, this is MRI from the same patient. This is called tigroid or sandwich sign, okay? And many people now believe that this is almost diagnostic of Bethlehem myopathy or Ullrich congenital muscular dystrophy. Yeah, this from outside to inside pattern of muscle fat infiltration. Yeah, and this is also called central shadow. And if you see this type of sign, you almost have diagnosis. So muscle imaging is very powerful. Yeah, and but more recently, actually, this is very, very rare condition, only one paper, a new limb-girdle muscular dystrophy caused by JAK2 mutation. They also show outside to inside pattern of fat infiltration. Yeah. Okay. Then, yeah, I already talked about it. And sarcoglycanopathy. The sarcoglycanopathy, they did, my friend, actually, Claudio, actually did a big MRI study as well. And he found that, yeah, okay, those sartorius and gracilis are well preserved, and lower leg muscles are also well preserved. And thigh muscles, adductors, and gluteal muscles and posterior thigh muscles are affected. And interestingly, if you look at the vastus muscle, vastus lateralis or vastus medialis muscle, proximal part is more severely affected than distal part. So the disease starts from proximal part to going to the distal part. And this is opposite to IBM, inclusion body myositis. In inclusion body myositis, you know, it starts from the distal parts and going out. So this is opposite. Yeah, and there are many alpha-dystroglycanopathies. I don't go into the detail. Yeah, so, but there are at least 18 different causative genes, now very complex, but I don't go into the details. And only one of the patients, you know, we have Fukuyama congenital muscular dystrophy. This is, of course, present on, you know, few patients in Korea and China, but most patients, almost all patients are present only in Japan because we share common mutation. Yes. So interestingly, typically patients have 3 kb insertion. That is the common mutation among Japanese Fukuyama congenital muscular dystrophy patients, and they have that mutation in homozygous mode. But this particular patient had 3 kb insertion in one allele. In the other allele, she had missense mutation and very, very mild phenotype. And she actually didn't recognize any muscle weakness, but she had cardiomyopathy and no Gowers sign, but she has calf muscle hypertrophy. So it looks like very, very mild muscular dystrophy. So even the same gene, the mutation in the same gene can cause really severe congenital muscular dystrophy to very mild limb-girdle muscular dystrophy. So the spectrum is very, very wide depending on the nature of the mutation. This is another patient, FKRP mutation. This is another alpha-dystroglycanopathy. So let's look at how he stands up. So you can tell he is already severely affected, right? And this maneuver is very similar to the Duchenne boy I showed before, right? Already affected, so you can tell. And of course, his quadriceps muscle is already affected like this. And alpha-dystroglycanopathy can be diagnosed by immunohistochemistry if you do a muscle biopsy. Alpha-dystroglycan is present like this, but staining is decreased like this in alpha-dystroglycanopathy patients. Really, another new one is PO-GLUT1. Yes, the Carmen also. She used to work in our lab for a while, years ago. So actually, she found that the MRI pattern is very interesting. This is from inside to outside pattern, opposite to collagen 6. So yeah, I don't go into the detail, but analyzing imaging data is very informative and can narrow down the disease, and also it can even make a diagnosis. Yeah. And finally, I'd like to point out, yeah, this one. Treatable conditions may look similar to limb-girdle muscular dystrophy. This is the last one. Yeah. So I didn't go into the detail, but you have to be careful because while like immune-mediated necrotizing myopathy or late onset pulmonary disease, some metabolic myopathies, can look like limb-girdle muscular dystrophy. So again, so as I mentioned yesterday, if you think you need muscle biopsy, you should do it right away. You shouldn't delay the diagnosis, because if you do muscle biopsy, of course, many of those cases can be diagnosed. Okay, that's all. Thank you very much.